name is Jonathan Wang, and I am the founder of the Youth Advocates for Global Health Association.
And my name is Matthew Yu, the Vice President of our organization. Today we are pleased to welcome Dr. Ove Peters, who is originally from Germany. So he completed his dental degree at the University of Kiel in Germany in 1990 and later worked at various academic institutions in Germany, including the University of Heidelberg, before moving on to positions in the United States and Australia. His early career in Germany included a role as an assistant professor of prosthodontics at Heidelberg University, which laid the foundation for a subsequent career in endodontics. And I'm sure Dr. Peters will tell us a lot more about himself throughout the webinar.
Yes, absolutely. We are so happy to have Dr. Peters share his insights with us today. And following the presentation, we will have a Q&A period where all webinar participants may submit their questions using the chat function.
Let's give a warm welcome to Dr. Peters. Thank you so much for joining us today.
Oh, thank you. I'm absolutely pleased to be with you. I think it's very powerful, and I think it's an excellent initiative. And it's quite fitting when I'm thinking of what you just said, what the purpose of this organization is, that I talk not about which file to use or what I think endodontics should be like, but a little bit more of a, let's say, formative structure going forward. And the question that I posed here is, what is optimal endodontic care and how do we get to this? So let's take a look what the standard viewpoint is. And I understand that most of you are in healthcare or perhaps even dentists. So we understand that endodontics is associated with inflammation, with bacterial causes for what's called periradicular inflammation. Right? And this is not new. This is, in fact, the disease concept that Dag Östervik had popularized in this book, and it has been around for a long time. So endodontic therapy, root canal treatment, vital part therapy, and the like, really in the end addresses prevention or resolution of periradicular inflammation. And this is a prehistoric skull where people already had apical radiolucent areas. That's taken out of the book along with Domenico Ricucci's beautiful histology. Why does this tooth have apical periodontitis? Because there was sufficient attrition, sufficient sand or other hard bodies in the diet. These are people that didn't have sweets, but they did have bacteria. So bacterial ingress produced this type of bony lesion. Now, what people don't realize is that apical periodontitis has a worldwide prevalence of 50%. So I'm looking at the screen and I'm seeing 5 of us, right? So at least 2 of us have apical periodontitis if the numbers don't lie. It's not me, so it has to be 2 of you. In fact, if you look at this on a worldwide scale, it could even more. Up to 60% has been reported, and 14% of teeth, of course, maybe 1 tooth or 2 teeth, or however many teeth per person. Root canal treated teeth that have been treated with various qualities present also with signs of apical periodontitis to a relatively high percentage that is shown here. We did a cone beam CT survey, and we found even higher numbers. Most of the original data is reliant on periapical radiographs, and of course, cone beam will show you cases more frequently that would probably escape this type of diagnosis if you take just a periapical film. So in fact, almost 80% of the subjects in this large survey had bone signs that are aligned with apical periodontitis. Maybe there's another way of looking at endodontic outcomes. So we talk about what is optimal care and look at retention. Ultimately, the failure of endodontic treatment occurs when the tooth is extracted, and there's excellent data to look at. This is 10-year outcome data from a public specialist clinic in Gothenburg, Sweden. And it's a pretty robust, well-documented, statistically really elegantly analyzed data set from Thomas Quist's group. And what we're seeing here is that 10-year survival is almost 82%. Out of the extracted teeth, and this is important in this group, the vast majority was removed for fracture and untreatable caries. Only 5, that's less than everybody else that I talked to would have expected, for non-treatable apical disease, endodontic pathosis. And the data shows a lot of other interesting factors in terms of crown placement, gender, age, and so forth, which you don't have enough time to analyze. But it's worthwhile because when we want to deliver optimal care, the question becomes optimal for who? See, and this is what I want to focus on today, is P for medicine, or perhaps P for dentistry, the answer when we ask the question, what is optimal care? This notion hasn't reached endodontics, but it has reached periodontics. This paper by Mark Bartolt and my colleague Sasha Ivanowski here in Brisbane was published just 2 years ago. P for perio makes somewhat sense according to those authors. And I want to explore if there is space for P for endodontics. What is P for medicine in the first place? That was a bit of an unknown for me, but living in the US, this was something that came up a couple of years ago. And this is just a relatively recent paper that talks about how medicine or systems medicine will transform the healthcare sector. I'm not in the business of predicting the future, but that's what these people do. What is this P4 in the end? It's a system-based disease model that looks at wellness, a positive outcome, rather than the absence of disease. If I'm asking you, when do you go to the dentist, have a positive experience, right? The positive experience is the absence of a negative experience. It didn't hurt, I didn't have any cavities, whatever. But a positive question, is there a gain, a net gain in wellness? In the viewpoint of these people, this underpinned by advances in biology and technology, and it's possible to have a net positive here. And this is a proactive care model, not reactive as we normally have it. You go to the dentist, maybe if you're diligent for checkups, but more often than not, patients go because they have a problem. They have pain or they have other issues that they need to be taken care of. They focus on the 4 areas that are shown in the little diagram in the bottom right here, and I will highlight these things in the next couple of minutes. First and foremost, we have to say this is not altruistic. This is not only because the world is a good place, but it's also a business model. It plays to a more sophisticated consumer viewpoint, and they look into new businesses, new services. And we see this every day if you look at what's being offered in the cities and also on the landscape as a whole. Principles are as follows. We have first P, predictive, meaning what kind of factors actually go into disease flow. Can we predict the possibilities of the disease, knowing all the underlying factors? And with this knowledge, can we actually prevent disease as a whole, and certainly negative potential consequences of the disease when it has been incepted? Personalized is another P, which is quite important. The notion of precision, personalized medicine is something that I want to explore also in the next couple of minutes. And the last P is participatory. I think, quite frankly, from my own perspective, this is probably one of the more important notions here. Only when the consumer is empowered to understand what the consequences are, can they be properly engaged in disease management. Crucial, I think, for today's consumers to be knowledgeable, to participate in their own well-being. So what does it mean for endodontics? Okay, so bear with me for a couple of minutes to understand this. So what is actually the predictive scenario that we're dealing with? We are kind of saying many times this way, we do anyway, if you have a dental problem, it's only a question of time when this becomes a more serious problem. For instance, pain. Is there a chance to predict from a condition that we see on the radiograph or in the patient what the probability of pain is? It's actually quite low. It's quite low, maybe 5% or less. And we have data to support this. What is the probability of losing a tooth that is endodontically treated? Also very low. We don't have good information about what is the probability of distant disease effects. I'm not talking about systemic disease like cardiovascular disease, Alzheimer's, or what have you, but it could be even local, like abscess formation, perhaps even life-threatening abscess formation. This is complex, and I will explore this as well in the next couple of slides. Now, what brings a patient to the emergency services in terms of dental practices? And this is a brief survey of Australian practices, and quite a few patients actually do show up in the practices for emergency only. That's a toothache consumer, if you will. And the typical presentation is for trauma, pulpoperiapical disease, and there are demographics and other issues that are associated more with the patients that come in for these emergency treatments. Social, and clinical factors. And preventive measures clearly will reduce this type of attendance to the dental practices, which, by the way, go along with poor outcomes, both from a patient-reported outcome side and clinical procedural outcomes. This is a very important, very underutilized study, actually. Yu and Messer out of Melbourne University, and they're looking at a methodology numerically to understand what is the likelihood for deterioration of a periapical relucent area. I told you before that a large number of cases that have root canal treated teeth have persistent apical periodontitis. So what kind of factors are actually associated with these conditions as somewhat in balance to actually deteriorate? And they have a couple of bits here, and this is before AI times, so they had to do an algorithm construction, almost like standard mathematics, and they used multiple regression analysis for that. And they understood that the risk in terms of further enlargement of a relucent area was somewhat medium, 30%. Is it high? Is it low? But the risk of pain is very low. They state firmly that apical periodontitis is compatible with health. And I have to question this, if it's 5% deterioration risk for a painful event, is it good or bad? And the question has to be asked in terms of over-treatment versus targeted care. If we start to treat every single patient that has apical periodontitis, every other person in the world has to come into our practices. That's not feasible. So who do we prioritize? And this becomes important when you think of potentially life-threatening risk associated with apical periodontitis. We call this avoidable hospitalization. This is just one of quite a number of studies out of Finland in this case. And the incidence of this significant event is actually on the rise in industrialized countries. I know numbers from the US, numbers from Australia, and numbers from Scandinavia. And that's a serious problem. There are patients dying at the moment from apical abscesses, like in this particular case. This patient survived, was treated by one of my colleagues here. And the presentation is very typical. It's a lower molar of a male in the 30s to 40s age bracket. Okay, this dental neglect. It's an untreated tooth, right? Maybe accessed, maybe never finished. This is reality. So something to think about. How can we manage this? By prevention. How to prevent disease initiation in endodontics? Quite simple, because it's associated with caries and associated microbiota, maybe also with trauma. Both of this could be prevented if we are going a little bit further in the scheme that exists already, certainly in fluoridation and trauma prevention. How can we prevent disease progression? By reducing and perhaps elimination of microbial challenge once initial treatment is completed. I'll give you a glimpse into history on this in a second. High quality primary treatment, be it just a cavity restoration, be it a vital pulp therapy or a root canal treatment. And third, how can we prevent general health effects like the ones I just showed you? We can certainly monitor and make the patient, you remember that I said participatory patients, make the patient come in for regular checkups, so a recall system and some kind of system where we can actually add value and demonstrate added value to the patient is decisive here. And we can try to target specific cases based on risk once we know what kind of algorithm we can use for that. Currently, we don't have this. It's not feasible. So preventive endodontics was been put on the map by Louis Grossman, father of endodontics in the US, already 50 years ago, right? So the text, this is the text here, peep in the past and the future, visionary, right? So what he says is this: the future must emphasize the need for preventive endodontics. This does not mean a root canal treatment just because they can, but it's meant to say prevention of pulpal disease. It would eliminate the need for endodontic treatment, except in the case of problems resulting from trauma. Pragmatically, this means prevention of the natural dentition by all means possible. Sounds logical, right? But we're not really doing this. If you look at it from a strategic perspective, I'm giving you this a very simplified chart when we divide case types as per global success rate. Remember, global success rate is not the same as the individual success rate, but you have to consider subsequent treatments. The global success rate drops if you start with certain treatments that are more complicated and perhaps have poorer outcomes. If we wait for a tooth to come to a state where the pulp is necrotic, the global success rate here in the middle is actually lower than if we initiated vital pulp therapy early on. And then you think of this also. While the global success rate drops, the cost and the technical requirements increases towards the right of this graph. Endodontic surgery, microscopes, calcium silicate cements, a lot of educational costs and so forth, which means that actually much fewer patients can participate in this type of care. Now, what is the driver for this diagram? And the driver is right here, and that's the ingress of bacteria. As soon as bacteria are firmly established in the root canal system, it's very unlikely that it will ever be completely eliminated. So if we can prevent bacterial ingress, we play at a much higher global success rate than if we don't. So that's the strategic background of all of these discussions. Let's very briefly talk about personalized endodontics, precision endodontics, if you will. We do this already. We as clinicians would say, yeah, we'll take each canal system, each patient on their own. Cone beam technology is being used, other imaging technology is being used. And what we don't do, though, is we don't look at individual microbial or genetic profiles of patients. Is this important? Let me show you a data set in a second, but it's certainly something we could do. And this is what P4 Medicine proposes. And then we can get actually a step further. While we don't have all the information from genetics alone, we can talk about epigenetics. Now it gets really a bit more complicated, and that's certainly not what you have in a daily practice in the next 10 years. What we could have is so-called digital twins, where we can reproduce the condition that we see in the mouth, at least from an imaging standpoint, to predict restoration quality and restoration longevity. Let me show you an example. There's a group in France, and this is a review paper, and that's their vision of how precision dentistry could unfold. And they contrast this to evidence-based dentistry. What is the big difference here? Evidence-based dentistry plays the big numbers game. Take 1,000 patients, you take 100 patients, and on average, this is the outcome. When you are looking at precision dentistry, you take one person and look at the outcome predictable for that one person. What they're doing here is just using AI, modeling, imaging, finite element analysis, and all kinds of other detailed methodological processes based on the data that has been obtained for this individual patient. Very technological at the moment. They don't have the ability to use biologic aspects. And it's also important to understand that this is very expensive. So equitability becomes a serious issue for this type of approach. Just to take a look at one of the images of this paper here, they just use a optimistic viewpoint and taking all kinds of imaging and finite element analysis in play in order to create a restoration. I'm not sure if this is good enough considering the technological and financial cost, but it's certainly one approach. If you want to go into biology, you have to believe in biomarkers, and biomarkers are ubiquitous, and for all kinds of medical interventions, biomarkers are being used. We did this paper here, and the question was, can biomarkers being used to understand pulpal inflammation? And our take home was, how do you do this? If you have to access the pulp chamber like here, and you take pulpal blood or can take periapical fluid, that's one thing, but we want to prevent pulpal exposure. We want to make sure that the pulp can stay viable. And so there's only a limited number of possibilities to obtain a fluid that could be analytically valuable. Others have said you can even go a step further, taking the right analyte, and you can end up, this is a small nuclear polyp polymorphisms, you can actually end up looking even at epigenetics and understand molecular targets in endodontics to avoid the pitfalls of the current strategy, where we have a treatment that affords benefit for a large group of patients, no benefit for a smaller group of patients, and perhaps even adverse events for yet an even smaller group of patients. And the data is clearly there. So this is just one, this is a wingless gene here. There's certain differentiable findings in terms of these SNPs. And that would allow us, if we knew what the particular epigenetic makeup of a patient is, to say, we provide personalized endodontics and can say, okay, it's benefit for every patient, predictably. I think it's wishful thinking at the moment, what could be done. Last but not least, participatory. How can we do this? Our healthcare is reflected in social media. We are talking to each other because you may have seen some of my information in social media, perhaps, I don't know, even though I'm not very active in social media. But clearly patients are educated through channels that are non-traditional. The commodity notion of healthcare is another story, but you notice that I said consumers, not necessarily patients. That all is part of a new paradigm that we are looking into going forward. So buy-in and engagement is critical for prevention. If patients are not willing and capable of playing along, no point. And it's quite interesting to think of what a sophisticated consumer could look like. It could be wearables, the Internet of Things, big data, all kinds of stuff. This will happen without being overly optimistic, pessimistic. I saw this paper here. And this is a group in China that uses oral wearable sensors. There's a whole bunch of things that could be done in terms of food intake, dental disease monitoring. I mean, this is all pie in the sky kind of ideas, but it's possible. It's possible. When you think of the metaverse, it's inevitable. We all are part of that. You know, everybody has a cell phone. Many have other wearables. It's possible. Biosensors do exist for the oral cavity, but understand this. We can measure pH, we can measure bite forces, food intake, and even osseointegration of an implant. An implant could have a sensor built into it, and the osseointegration could be measured that way. But the oral cavity is a harsh environment. It's not so easy. There couldn't be any cables, there couldn't be any batteries. How reliable is this? What's the service life for a sensor like that? Not going to happen, but it's possible. Not going to happen, I should say, overnight, but it's possible. All of these things are just elements of the participatory wrinkle that I want to at least address. I have a couple more slides here to conclude why I'm saying these things the way I say them. The standard expectation for endodontic treatment is outcomes oriented. First of all, we need to know what the outcomes are. And this is true for all other medicine, of course, as well. It has to be patient-centered. First and foremost, we have to get away from us, the providers, providing the treatment that we think the best. And we have to have also an evidence-based approach to that. That's traditionally probably contemporary even what the outcome or the scenario is going to be. Now, when you talk about endodontics, and we talk about periodontics as well, by the way, inflammation is a big driver of disease here. And one of the things that is happening right now that I'm thinking is very important is the use of dental dedicated MRI systems for inflammation understanding. So it's radiation free, obviously, and we can really look at soft tissue conditions, even without any injectable therapeutics and diagnostics. We can understand what the tissue conditions are. And it's just a teaser because these machines are on the market as experimental at the moment. And it is realistic. I'm very positive on this, but the main issue at the moment is cost. The potential is untapped and will occur in the next 5 years. There's just one image out of this paper. This was published earlier this year, and you got to realistically understand from our mindset on this. Of course, the color codes or the gray level codes are transcribed. This is normal is dentin, enamel here, and this is the pulp space, right? This is an apical radiolucent area here that comes across as white, and depending on how the specific setting of the MRI system changed, you can understand if this is scar tissue. You can understand if an abscess is forming here, or there's a pro-healing phenotype that this tissue is shunted towards. I think quite dramatic. That gives us an ability to think of lifelong endodontic health. Endodontic disease, pulpal periapical inflammation, we can understand how it's managed in the lifetime of a patient, and that drives decision-making of what we need to do. So we can actually say then, what is for this particular patient the best therapy? We can consider factors, retention, function, patient's means, and so forth. So we can tie things together much better. What is a challenge is how does it play in terms of cost effectiveness? These are very expensive devices, of course, and education and facilities and so forth go into that. But even for today, a lot of stuff that's being done is not necessarily the best for our patients. So what is optimal care then? On an individual level, it's an improvement of wellness. Not just an absence of pain, irrespective of the strategy. And it's based on an intervention, action, or perhaps non-action, depending on what the scenario is presenting itself. On the population level, prophylaxis. From caries, trauma prevention, pulpal breakdown, and so forth, as I mentioned before. And the strategy needs to change significantly. Incentives are monetary. More often than not, this works just by the way the fee schedule is set up. Only that can affect change really. If the fee schedule stays the same, behavior of individuals in the marketplace will stay very similarly. Elements of this P4 notion can help. And for me, as I said before, most importantly, the notion of participatory care. This is all what I have to say to this topic. I'm developing this much more at the moment, but for me, it's quite important, and I think it ties in very neatly with a more global kind of scenario that we are facing once we solve the problem of the one patient in one chair opposite a provider. That's what we all do on a daily basis anyway in healthcare. But that's not good enough. I think it's a question of what about all the others who could not participate in that type of care. So I'll give it back to you, Jonathan, and to you, Matthew, Cindy, and Karen, and I'm looking forward to discussing this further.
Yes, thank you, Dr. Peters, for your very enlightening presentation on P4 principles in endodontics. Could you please elaborate on the most promising preventative strategies in endodontics that align with the P4 medicine approach?
Yeah, so I think by nature, prevention in this case is prevention of pulpal breakdown. So in other words, vital pulp therapy. So just understanding that vital pulp therapy is a useful and practical approach. I give you an example here. So the patient that came in with the large swelling that were operated on by my colleague Nigel here, this is a patient that lives in Central Australia. There's no dentist, okay, in the next 500 kilometers. So he makes a trip to one dentist one time in a year, and this dentist just axes a tooth, and the patient never returns to this dentist. If this dentist had known how to manage a tooth with vital pulp therapy, flying doctor service, if these individuals know how to provide vital pulp therapy, it can prevent a lot of further issues. A patient will come, that type of patient, and there's quite a few, will come when there is pain, right? So once pain is removed, canals are cleaned out, or maybe a restoration is placed, or whatever, patients are not necessarily going to come back. So prevention of bacterial ingress is probably the most powerful strategy in my area of expertise at endodontics. We cannot eliminate the bacteria in the oral cavity, right? As much as we try, because we need them to some extent or another. People have tried to do this with vaccination against caries and all other antimicrobial measures that has not proven successful. So unless that changes, we have to use local systems to prevent bacterial ingress and establishment. Think about this: even a deep pulpotomy, not necessarily just I'm not talking about direct pulp cap or anything like that. Talk about full pulp chamber pulpotomy or deep pulpotomy mid-root. All of which allows bacteria not to establish or prevents bacteria from establishing themselves deep in the root canal system. That's prevention. That's, I think, the most powerful thing that we can do in the now.
Absolutely. And these things would definitely prevent a lot of people from having to do invasive endodontic procedures, I can predict.
No, 100%. They are costly. I give you a very practical example, right? So you are Las Vegas, right? Las Vegas, Nevada. So you're in Canada. Canada is a bit of a different setup, but in the US, you have a lot of underinsured or uninsured individuals. Las Vegas doesn't have a postgrad program. Ron Lemon, the program head there for the undergraduate endodontic section, is a firm believer in vital pop therapy. This particular demographic that they're dealing with is younger, uninsured, and has primary disease. It's very different if you, let's say, are in the city of New York or in Zurich or some other place where a lot of dentistry has already been afforded to these people. And we have a lot of, let's say, already root canal treated teeth. But let's come back to Las Vegas. You have the ability for these patients, and he's given me numbers from 100 patients that come to the dental school clinic to receive a root canal treatment. I think 2/3 are actually getting vital pulp therapy, meaning many of these teeth are still vital. Okay, so there's a significant opportunity to avoid those types of treatments.
Yeah, that's those are all really, really important preventative measures. And on the topic of that, so from the past webinars, we've noticed a pattern. I think all of the health professionals that we've talked to have brought this point about education and about kind of the patients really knowing what's going on. For instance, Dr. Rose Leishman, who is working in a Central African Republic, was telling us how a lot of people don't know about the health risks there. And we were talking to Dr. Thomas Yu, who is in periodontists. He said a lot of people don't know they have gum decay and don't know they have a lot of these problems. So what are some ways that we can improve awareness and that can really help preventative kind of measures?
So, well, you're doing it right now. To make it accessible to another population that doesn't necessarily have access to information. So the online media or the social media constructs that we have at the moment are so much more accessible. And it's amazing how much information, good information, could be in there. The question is, how does content actually get to individuals? I give you an example. We have a homeless population here in Brisbane, in my city. That's fairly small. But I was told the other day that they have their own mobile phones. And there's certain areas in the city where you have free internet access. So you can even reach those types of individuals. I don't know, in Africa, I understand there's also a lot of mobile phone usage. So it is definitely possible to reach a sizable population through these channels. The only problem is, how do they differentiate between misinformation and good information? So I think the most important bit here is to bring this accessible information to online media and make it sufficiently appealing for those who need to know this, not to be swayed by conspiracy theories or all kinds of obvious incorrect things. I don't want to talk about politics, but if you think about it, fluoridation, right? Fluoridation has a very clear health benefit. Yet there is still a lot of conspiracy theories swirling around that maybe fluoridation could affect mental capacity, and even worse things could happen to people that are subjected to fluoride, which is demonstrably false, right? And so also in locations where it's quite important, these things have to be part of the curriculum. Let's say schools, right? So I used to live in Switzerland for a number of years, and Swiss schools have a curriculum that has our hygiene as part of it, right? So typically a Swiss 20-year-old has no gum disease, no cavities. A typical 60-year-old that went through this program would have maybe one restoration. So it is possible, but it needs to be done with government input, and it needs to be done in a way that people can actually be taken along. I think what we're witnessing right now is the notion that a lot of individuals don't believe what the government says, for better or worse. So it has to come from multiple sources. It's not one thing, but it's really a multi-pronged approach that we have to take here.
Yeah, I totally agree. Like fighting confirmation bias and also misinformation. Yeah, these are big things, and using the media wisely to get more informed, especially about health, is very important. I just
Yeah.
had a question about like how like from what I've noticed, not many healthcare professionals at the moment are incorporating P4 principles. So what would you say is the biggest challenge in implementing these principles in healthcare in general?
Well, first of all, people have to believe in it. I'm not telling you that I firmly believe in it. I think it's a little too early to say this. I think this is an opportunity, and we have to understand what are the useful parameters that I already mentioned, participatory care. How do we get this across? We have to be very careful that this doesn't become a commercializable or monetary kind of use. I mean, overtreatment is a significant issue either way. Overtreatment could also be, if you think about it, 80% of all patients have no real benefit from annual or even 6 months cleaning, right? Only 20%. Yet we prescribe this for 100% of the patients. So this is a very typical finding. And so if we could personalize this better, we probably save money. But if we are using so much money to understand the risk, then we are too preoccupied with potential risk, then we overtreat the individual. So there's understanding it better is probably the first thing that we have to do. P4 medicine hasn't really taken on to the level that Lira Hood certainly anticipated. So maybe it's too early. It's probably visionary at the moment. In dentistry, and particularly in endodontics versus periodontics, the problem is also to create the scientific underpinning properly. In perio, we have the right diagnostic tools to find nuances in disease. In many other diseases, we don't have this, certainly not in endodontics. The pulp condition is a mystery for us. We can describe some endpoints, but because pulpal breakdown is spatially and temporally graded, we cannot know currently what we're actually dealing with. In apical periodontitis, there's still a lot of discussion. Is this chronic condition that will not change, or is healing going to occur? We don't have a lot of information. So that's why I highlighted MRI as one of the tools. That leads then to cost. How can we do this? So plus, maybe let me be a little provocative here. Too many are very happy with the status quo. They make enough money. They have their framework, what they should do, and they do it, and they go home.
Yeah, thank you for your input there. It looks like we do have a few questions coming in the chat. So the first question we have is, as root canal therapy becomes more streamlined with advances in technology, do you anticipate any changes to the training or skill set required for future endodontists?
Maybe not for specialists at the moment. And in the future is a big word, right? Is the future the next 5 to 10 years, or are we talking about the next 50 years? Next 5 to 10 years, I don't really see any big changes for that. What I do see is more changes in the undergraduate, at the undergraduate level. And one of the bits here is to really be more stringent in case selection. And certainly when you think of the North American market, just allowing vital pulp therapy to happen is a big difference. When I was in San Francisco, we wrote a paper or two on this, so we had this on the schedule, but it's still not very typical. So when I was in private practice and somebody sends me a patient for a root canal treatment, they would expect a root canal treatment to occur. And as much as I would like to do a vital pulp therapy, I have to play in this triangle between my referrer, the patient, and myself. So that's going to happen. The technology, if you think about it, has not really changed significantly in the last 20 years. So microscope was introduced, rotary were introduced mid-90s, maybe early 90s. And so that's even more than 20 years, almost 30 years, right? So we have different disinfection devices, but none of these things is fundamentally going to change what we do. And there's non-instrumental techniques and so forth. I predict already sitting here happily in my office with a beautiful sky outside in the summer in the southern hemisphere. It's not going to change the world significantly. And there's good reason to believe this, because it's not going to eradicate microbial load. So unfortunately, as much as I wish to say in 10 years you will do that, not going to happen. It will be more of the same.
Yeah.
Yes.
I know the future is a very big word and there are many
That's right.
things going on. But on
Right.
that topic, we were thinking what your thoughts are on the potential of 3D printing in personalized endodontic treatments.
Yeah, this French paper talks about this a little bit. 3D printing is good, but to which end? We do a couple of things in this. I've had for years a long-standing track record in 3D data and so forth. So we did a couple of things in San Francisco, and we do more here. It can be good for educational purposes. It could be for self-education for an individual patient. Pre-surgically, you print out the jaw of the patient you're going to operate on, or for a patient that has a highly mineralized anterior, you print a drill guide. Even for surgery, sometimes we do drill guides, not very often because we have an easier access for surgery for the most part. So yes, it's possible, but it's a small fraction of patients where this is decisive. I give you the drill guide as a pertinent example. For a posterior tooth, a drill guide that provides a straight line is risky because sometimes we have to change the path of access. For an anterior tooth, where the axis is more like a straight line, when you come in from the incisal edge, you can work with the drill guide very well. So I'm not sure that the 3D data is going to be the answer for that. It's one tool in the armamentarium, but if you ask me for a percentage of cases, maybe 15 to 20%, but not for 80% of the patient, is that going to make a big difference? Very different and restorative.
Yes, absolutely. We have a question here in the chat box that says, what do you think is the most misunderstood aspect of root canal therapy? And how can dental professionals better educate the public about its
I
benefits?
think conventionally people associate all kinds of endodontics with pain. Barack Obama is on the record, like many others, it's not as bad as a root canal, right? So I think that's the most misunderstood scenario. My background is in neurobiology, and we know how the pain perception and the whole pain origin functions. Root canal treatments are not necessarily painful. I don't like to sit in the dental chair. And I would, at least not in the dentist's chair. I'm thinking of the big chair where the patient sits. So the fact of the matter is we all have to only look at our own behaviors. I wanted to mandate, and I was not successful with that, that every resident, every postgrad that comes to us has to undergo one root canal treatment and one surgical procedure themselves. And nobody wanted to do that. So I've stopped even bringing this up. We need to be able to position ourselves in the chair and feel what the patient feels, at least to a reasonable extent. How can, yeah, that's the most misunderstood aspect. How can dental professionals better educate the public? I think the AE, the American Association of Endodontists, is doing a reasonably good job. The one thing that I'm worried about this sometimes is if we, as the providers of that service, educate, because it can come across as a bit self-serving. Okay, all of these campaigns will go back to the patient and say, yeah, but you're doing this only because you want to make money off me. Okay, so if I have a better system, I'll let you know. I don't have a better system at the moment. I think the picture of dentistry in the population is not very good. I don't know if this is the case in Canada as well, but they're certainly not in Europe, and most certainly not here in Australia. So dentists are not necessarily seen as altruistic or positive characters. In fact, sometimes in the movies, the dentists are seen negative and maybe sadistic even. So many aspects, For instance, one of the things that we are doing here is bringing school kids to the school of dentistry, so that they can see what's going on here. And it's a long journey. It's a long journey. The benefits begin with ability to retain the natural dentition. As the population ages, significantly ages, we notice a lot of issues in nursing homes and with elderly people. So as soon as that becomes a bit clearer, and I think we are in the right way here, then we have already set this in motion. What was the most challenging case? I wasn't necessarily prepared for that. There's many challenging cases for a variety of reasons, and I couldn't even say one particular case. So it comes with the territory. The longer you do this, the more you see either patients that are management issues, or you have technological issues, or you have incompatibility between me in this case and the patient. I wouldn't pinpoint one particularly challenging case. That's too many to mention, and it could be for a totally different webinar. I think there were many, and everybody will have these. And maybe the one piece of advice or information that I have gleaned from that is we have to find an equilibrium with what we have done. If you beat yourself up the next day and said, we didn't manage this well, it's not going to help anybody. So the only thing can be that we resolve to do a better job the next time. That's the way I approach it. If we're saying, okay, crown margin is 99% perfect, and you get beat up by the 1% that's not perfect, or you have a 4-canaled tooth, and out of the 4 canals, one has a little void somewhere. And you say, oh man, I wish I wasn't like that. So in some way, we have to think of, okay, why did it happen? Is it relevant? What do we do to avoid it next time? That's probably the way I approach this.
Yeah, I really like that idea of basically learning from previous mistakes to become a better healthcare practitioner.
Mm.
I just wanted to ask about the role of nanotechnology in the
Yeah.
future of endodontic treatments.
It's already in there. So evolving is what it's doing at the moment, but there's this is such a broad field. There's a whole bunch of different things, and it could be in the disinfection area. It could be certainly in the ability to functionalize cements or other materials. So what we're doing at the moment, we try to nano-functionalize instrument surfaces. So the beauty of nanotechnology is that you can try to ascribe new properties to things that you already have. So when you think of, for instance, MTA, so these particles that are in the MTA material could be changed in their surface, or could be loaded up with certain other, let's say, pharmaceuticals, if you will. So there's a bunch of different things. I think functionalization is what nanotechnology can give us. Things that we already have that can, rather than being inert or more bland, can have a let's say a gain of function mutation, if you want to call it from a biological standpoint. That's happening. So we do a lot of work in this area, both with surfaces and compounds, and it could be very meaningful also in conjunction with diagnostics. These nanoparticles could actually function, and there's a whole department in one of our institutes here as nanodiagnostics. That they could be MRI connected, and there's a lot of possibilities. I just finished a grant review session for the large grant giving agency here, and I would say half of the proposals that I reviewed had some kind of nanotechnology component. So this is certainly going to continue a hot topic. There's downside. We don't know what the biological response is, where these things go. Are they going to accumulate somewhere? If they're not inert, that could also mean they have negative consequences, right? So there's always a little biosafety concern that is in the back of my head, even if this is a far out technology. But it's going to be here, that's for sure.
We just had one last question come into the chat. So, given the interdisciplinary nature of modern dental care, how important is the collaboration between endodontists and other specialists in providing comprehensive care for complex cases?
That's an excellent question. Couldn't be underestimated. Look, and what's the practice model of the future, right? My father is a dentist, and he worked by himself on this small island in the North Atlantic where I grew up, and he would never talk to anybody. He would try to do everything himself. This is not going to be workable anymore. So clearly, communication is crucial. And it's not only between endodontist and restorative dentist and patient. It's hard to know what kind of specific development those take in individual countries. But I see in the US and North America in general, these large DSOs forming with a different pool of specialists, different pool of generalists. And that by its very nature already brings up communication pathways among these individuals. That's also happening in Scandinavia, by the way. Here in Australia, there's only very small at the moment. So it lags behind, but it's certainly going to happen as well. So I think it's crucial. If the patient, this is quite interesting to think about it. So grant applications now need to have a consumer liaison. So all the clinical studies have patient advocates based in this, and even in the design of the study. If the patient is a participatory member of this team, they have to be able to talk to everybody that is in this team at an eye-to-eye level. And that's true for a specialist, general dentist, and maybe dental hygienist or anybody else in this team. That's a tall order. It's not going to happen for everybody, and certainly not overnight. But in the future, I'm pretty sure this will have to happen in order to make the best value add treatment out of what we can do.
Yes. To conclude our Q&A session, Matthew and I have prepared a few questions about your very interesting career. We know that your career has spanned several continents. So first of all, I'd like to ask you what initially inspired your decision to relocate to Australia from the United States?
Yeah, I've seen this question in your mind a little bit coming up, and you're not the only one asking that. It's multiple things, right? So I had reached a bit of a limit of what I was able to be able to do, and I didn't. I want to be honest. I didn't really like the way things were going in the US in general, and my kids were at an age where they were at the end of their high school years. And if we didn't move at that moment, we would have never moved. My wife doesn't necessarily like what I'm saying, but I had a discussion with my retirement broker, and he says, by the way, and this is in San Francisco, right? He says, by the way, when you retire, you have to sell your house. I said, maybe I should sell my house right now. And so we ended up doing that. So it was more like accumulation of certain things. And as you said before, I didn't grow up in the US. I grew up in Europe, and so it was not like I had to leave everything behind that I had only lived with my whole life. It made it a bit easier for me. Easy for my children, though, who grew up in California. So it was over a couple of years a decision that accumulated ultimately in obtaining this position here in Australia.
Next, we just wanted to kind of understand your background a little bit more. So we're wondering, why did you decide to go into the field of endodontics? Could you tell us a little bit about that?
I can certainly do that, and I will make it a very brief, a very long, and I think, quite interesting story. So, as I said, my father was a dentist. I didn't want to be a dentist. He studied medicine at the beginning, didn't like it, and ended up being a dental student. And I worked in the physiology department as a research student during my dental degree. And in Germany, there's a mandatory military service, and I got around the military service because I sued the country for replacement service. So I'm still working in physiology, and then the Berlin Wall came down, and that opened the door for me to be a full-time staff member in physiology. Because and I stayed there for 2 years, and I learned a lot about pain and pain management and so forth. And after a couple of trials and tribulations, including PROS, where I was working with functional myofascial pain, and that was very difficult to manage, I got the offer to work at Zurich University. And they are starting at that time we're talking about 1994, they were starting an endodontic department from scratch. You know, they had money, and so had opinion leaders from the US to help start the program. And I had some papers in pain biology, and apparently already at that time, somewhat of an interesting CV. And they said, "Oh, why don't you come to Zurich?" So, okay, I came to Zurich, and there was a very strong restorative department at that time, still is today, but at that time it was probably the strongest in Europe. And I said to the department head, but I have also this girlfriend of mine, right, who is also a dentist, of course. And he says to me, "Is she any good?" I said, "Yeah, she's fabulous." I said, "Okay, then she gets a position too." And so we came to Zurich and developed the endodontic the curriculum there, did a lot of research, and had a lot of excellent support by good people, right? So it's a little bit of a chance scenario, but it's also you have to be in the right at the right time and have the right support and the good people to work with you. And I was very fortunate that there were quite a few people. The moment was right too. Don't forget, you know, this was a really uprising, very positive, innovative climate. You know, the new technologies, the microscope, and all of that. This was ripe for somebody to take it on.
Yes. When I was preparing for this webinar, I actually happened to come across an article that stated that your wife, Mrs. Christine Peters, is also in dentistry. So I also learned that you have two children. Do you think they have any interest in pursuing dentistry someday?
And the answer is 3 children. None of them is interested in dentistry.
Oh wow, that's quite a surprise.
Yeah, yeah. Not because we have portrayed it in a negative way, but they're different people themselves. So our son, the oldest, is doing environmental sciences. So he's politically very interested, and he feels like he can do more for what he wants to do himself than as a physician. He wanted to be a physician, but said, no, maybe it's not the right thing. The next one, she is a double major in psychology and business. So she is a good people's person, and she has a good hand skill set, but she never wanted the stress level that comes with that type of endeavor. And we have to be honest. I mean, this is not a stressless environment. And the youngest is still at high school, and she probably will be a physician at some point. That's what she says now, but that's really no. And we have never pushed, right? And neither has my father, right? My father is retired for many years, but he never pushed. Christine's, my wife's parents, were very keen that she becomes a dentist for some reason or another, and she agreed with that. And even though that her parents are teachers, so no, the answer is very simply none of them has shown any interest whatsoever.
That's so funny. I mean, well, your father passed on dentistry to you, and I guess it's gonna be difficult for you to pass it on to the next generation. But who knows? Anything is possible. Um, we're just wondering, um, what advice would you give to maybe young dentists considering a career in endodontics or maybe in the broader medical field, you know, just in general?
There's many things I can say. There's many things I can say. So, but I give you the one thing that I, as an let's say an interviewer or as a person who makes decisions, if somebody gets on board, look for is the fire in the belly. If somebody is truly, clearly enthusiastic, that's it, right? How do you get to that? So, of course, sometimes I see people that are in this for the money, and that's fair, right? I don't like it, but that's okay. But if I see somebody who is really truly interested, and there's many things where you can pinpoint this, that's it, right? That's it. The fire in the belly. So here in the Australian system, you have the ability to put priorities in, up to 2 or 3 priorities. You apply for postgrad. And for those people that apply for endodontics in step 2 of the 3 possibilities, I don't even consider this. How can we be passionate for orthodontics and endodontics at the same time? Couldn't be any more different. So I think there is no fire in the belly. Ken Hargreaves, one of the major movers and shakers in endodontics in the US, calls this the 3 H's, right? Heart, hands and horsepower. That's what we look for. Horsepower being raw intellectual ability. How can they actually put one and one together? But how do you get to this point? You have to demonstrate that you really have these things. Horsepower, I'm not asking them to write a paper, come in as an applicant with a finished manuscript. Hands, there's no test where hand skills are tested. And heart is essentially also the fire in the belly. How can we transmit, if you have it, that you're really enthusiastic? There's lots of things. So I've worked with two Canadian students of Korean origin from Vancouver, BC, right? The Choi brothers. And they're so passionate. It's fabulous. So they have now both have gotten into the endo program at Loma Linda in Los Angeles, in Southern California. And it was obvious. And you can tell when you do this long enough if somebody is really truly motivated and wants to do this. That's the most important advice. Be genuine, be yourself, and do it for the right reasons.
Exactly. Yeah, doing it for the greater good. We have one last question for you today. So, after such a distinguished career, you've come so far. What do you see yourself in your retirement? Do you see yourself retiring in Australia, or is there somewhere else you're planning on going?
It's a very good question. If I have all the answers, I'll let you know. So it depends what my children will do, right? So Christine and I talk about this a lot, and I'm not going to give you all the ins and outs of the gory details of a couple that has been married for 30 years. But I'll probably stay here for most of the year, but I have lots of other things that I would like to do. So my mother passed away unfortunately last year, but my father is still alive, is in Germany, and so I have obligations and also willpower to go to visit him. Of course, my two brothers are in Germany. I have still friends in the San Francisco Bay Area, so I'll still like to travel. I like to see new things, but I probably spend a significant amount of the year here. I absolutely love it out here, I have to say. And it's such an uncharted territory place, right? There's still in the Northern Territory, there's still locations where I've not been, and Western Australia where I've not been. Lots to explore. What I can tell you is I'm not going to stick to this particular chair, which is very comfortable and very nice and a nice office. I'm not going to stick to this chair until I'm 80 years old. That's not the plan. But I want to contribute to different things, not necessarily only dentistry. There's so many other things I'd rather do. But once I'm here, as long as I'm here and capable, I'll try to move the field forward. And then maybe I'll learn some new things, like learn to cook, which I'm really very bad at. Yeah, hopefully I'll stay healthy. That's the most important part. And see, when my kids are too young yet, but maybe they have grandchildren at some point. We'll see. That's a long ways out.
For sure. Well, yes, thank you so much, Dr. Peters. We could talk for hours, but unfortunately, it has to come to an end. We really appreciate your time to speak with us today.
Yeah, thank you so
No,
much
of course,
for
of
joining
course.
us.
It's an absolute pleasure. Like I said, it's an unusual connection, and I love doing these things, as you can say. And you know, I truly believe at what you're saying, what I'm seeing to the right of your face here. Together, we can make a difference, right? You have a very good, surprising, right? Very surprising. I say this because I had not seen this. I had not encountered your organization. Uh, that's really to be applauded. That's phenomenal. So good stuff. Thank you very much for having me on, and hopefully it was useful for you guys.
That's very much so. This is Youth Advocates for Global Health Association, a nonprofit organization striving for global health equity. So thank you to our audience for watching today's webinar. We hope you've enjoyed it. To attend our future events and to register, please visit yagha.org. Thank you again, Dr. Peters.
Anytime. Bye-bye.